Good morning, everyone. My name is Justin Jeffers. I am a pediatric emergency medicine physician at Johns Hopkins, and I'm also co-chair of the education committee for IPSS and sponsoring the webinar today. For those of you who are not IPSS members, please consider joining so that IPSS can continue to promote and support multidisciplinary simulation-based education, training, and research in all subspecialties that care for infants and children, as well as be able to offer programs like this webinar in the future. So please check out the website at www.ipssglobal.org to see the benefits of membership and what it can offer you. A few other quick housekeeping notes before we get to the presentation. One, please feel free to post questions during the session. On your GoToWebinar control panel, there's a tab about halfway down that says questions. If you click the arrow, you should be able to type in a question, and we will try to get through all the questions at the end of the presentation. Today, I'm going to introduce Brittany Dahlin and Samreen Vora to give their webinar today. This is another webinar in our series of award winners from past IPSSW meetings. And so today they're going to discuss operationalizing a simulation-based mastery learning curriculum in a hospital-based setting. They will describe the nuances of using an SBML format for a variety of practicing healthcare professionals, including providers, nurses, and allied health. They will share an overview of the current cutting-edge research utilizing SBML curricula with the goal of preventable harm reduction. Brittany Dahlin is a clinical education specialist for simulation-based mastery learning at Children's Minnesota. Her clinical background includes pediatric hematology, oncology, and cardiac intensive care. In her role as an educator and simulationist, Brittany is interested in utilizing simulation to target preventable harm reduction. She has presented on the use of simulation-based mastery learning with practicing health professionals at various national and international conferences. Brittany's research focus is investigating the translational outcomes of SBML across various disciplines. Brittany's work was recently published in Clinical Simulation in Nursing. Dr. Samreen Vora is the Medical Director of Simulation at Children's Minnesota. Dr. Vora is a board-certified emergency physician who completed her medical degree from Chicago Medical School and her emergency medicine residency at University of Illinois Peoria, OSF St. Francis Medical Center. Dr. Vora has a master's in healthcare administration and management from Rosalind Franklin University. After emergency medicine residency, Dr. Vora pursued her passion for simulation by completing a 2-year fellowship in simulation and medical education, incorporating a master's in health professions education at University of Illinois at Chicago. Dr. Vora was part of the Emergency Medicine Simulation Fellowship Curriculum Development Task Force and worked with a team to publish national curriculum guidelines for EM simulation fellowships. Dr. Vora has presented widely both regionally, nationally, and internationally on a variety of simulation and medical education topics. In addition to the work related to simulation-based mastery learning curricula, Dr. Vora's current research focuses on the role of implicit bias in simulation education. And so with that, I will turn things over to Brittany and Dr. Vora and look forward to the presentation. Thank you.
Thank you, Justin, for that introduction. And thank you to IPSS for inviting us to share our work through this venue. It's very exciting to be able to do this. We've just got our disclaimer here. Neither Brittany or I have anything to disclaim or to claim or any conflicts of interest. And just to note that this presentation is material from us that Children's neither endorses or doesn't endorse. So we just wanted to start with a few polling questions just to get an idea of who our audience is and what your background is. And so I'm going to pass it to Monica. Our first question is really about general simulation-based mastery learning. We're just curious to hear if those in the audience have, if you're familiar with it at all, if you're very familiar, somewhat familiar, or not at all familiar. And it's okay if you're not at all familiar. This just will help us figure out how much we'll talk about kind of the background before we jump into our specific research at Children's. So we'll give you a minute just to go ahead and answer that question. So it does say should we be able to see those polling results? Okay. Well,
Caitlin, should we be able to see those polling results on the screen?
It did pop up on my screen and then went back to the question.
Okay. What did you see, Justin? Because we didn't see it pop up. Can you just summarize for us?
Yeah, sure. So it was 10% not at all familiar, 60% somewhat familiar, and 30% very familiar.
Perfect. Okay, yeah. And then we have one more question that we wanted to ask. There we go. So have you implemented an SBML curriculum? And we've broken it up into different academic settings and with different participants. So just curious to see what others are doing. And Justin, do you mind summarizing for us again?
Sure. 45% no, 27% yes in a medical academic setting, 9% yes in a nursing or allied health academic setting, 0 for in a hospital-based setting with students, and 18% yes in a hospital-based setting with practicing health professionals.
Well, that's cool. I think that we're surprised to hear, so we were really kind of wondering about those working in the hospital-based setting with practicing health professionals. We didn't think that was super common. So we're excited to hear from that 18% as we maybe near the end. We'd love to hear from you and hear kind of what you've done and how you've used sim-based mastery. So we'll just go ahead and start. And so just based on, it seems like the audience is kind of right in the middle there, somewhat familiar with sim-based mastery. And so just to make sure we all have a shared mental model of what we're talking about, we're going to start with just a little kind of background on sim-based mastery, where it came from and what it is. Brittany, actually, as you heard in the introduction, her role, she started here as a fellow, and her first project was using simulation-based mastery learning with nurses. And so after that project, they actually created a role for her as the clinical education specialist for simulation-based mastery learning for the entire hospital system, which is pretty unique. I don't know that I've heard of something like that anywhere else across the country. And so that was really cool. And she really ran with that baton and has done a lot of things here at Children's. And then we also, after she started that role, we were then able to attend the simulation-based mastery learning course at Northwestern, where Bill McGahee is and kind of is the father of starting this work. And so that was really cool. And so I'm going to pass it to her, and we'll just start with a little background, and then she'll give a synopsis of some of the pilot work that she did, and how we moved from that to a little bit broader work within a bigger unit, and then how we've kind of used that with other allied health professionals in the hospital-based setting. So,
perfect. So I just want to do a kind of background overview with sim-based mastery. So we have this kind of flow diagram on the screen right now, and MPS there, just for those who are not familiar, just minimum passing standard. So basically a cut score, or the spot you're hoping all your learners will get to. So with simulation-based mastery learning, there are some key pieces that really set it apart from other versions of assessment. And the first thing would be that pretest. So some sort of baseline, figuring out where each learner is. And you would use an assessment tool that's been developed through a rigorous process with content experts in order to evaluate all of your learners against the same constructs. And then if they met the minimum passing standard in that pretest, they're done. They go on to whatever your follow-up and maintenance plan is, and then, you know, they would maybe move on to another unit that you have sequenced in a curriculum. But those who don't meet the minimum passing standard, they will go on to deliberate practice, which really they would have these pieces that they need to, that have been identified in the baseline assessment that they would focus on in their deliberate practice. And they can self-select how they want to do that deliberate practice. It might be with a content expert, you know, helping them do more hands-on simulation, or it might be that they want to review an article or watch a video or what have you. So really it allows people to do what works best for them, but all using the information they gathered from that baseline assessment. And then our goal is that they meet that minimum passing standard in a post-test that would be on a separate day from that deliberate practice session. And if they don't meet it, then they just go back and they do more deliberate practice. So really the construct is everybody can get there. It's just a varying amount of time that it requires for each learner, which is definitely what we have seen at children.
And it's based, and so every learner, every time, and really this conceptual framework of simulation-based mastery learning is based in an educational strategy or conceptual framework of mastery learning, which was around for quite a long time, the idea of every learner, every time. And so adapting it into simulation almost felt pretty natural to be able to do that.
So where we started, as Dr. Bora described, was with a small initial study in our cardiac ICU. I was a research fellow and interested in supporting nurses in the practice of central line maintenance cares, and noticed that there was just a lot of variation in really the cares that were being provided. And our current education process at that time was really, once they completed orientation, it was assumed that people really should be able to maintain these skills as they were doing them nearly every shift with this type of patient population. So really it was a see one, do one, teach one during orientation, and then it was really relatively rare to really even have refreshers after that fact, because these are highly skilled, experienced nurses. And unfortunately, although we have low CLABSI rates, they aren't zero, and as part of our institution's efforts to decrease all preventable harm, CLABSIs are part of this Journey to Zero collaborative that we belong to as a part of Solutions for Patient Safety as well. So really, this initial work was in an effort to see, could simulation-based mastery help us improve adherence to our policies and also maybe even decrease CLABSIs. So this first group was, first of all, we had to create the assessment tool. It mirrored our institutional policy, which is based on CDC recommendations, and again, that Solutions for Patient Safety bundles. And that assessment tool allowed us then to go and see where are people at on this cardiac ICU unit. We did a convenient sample of 20 nurses, and they were diverse in the shifts that they worked, the educational background that they had. Some had masters, some had associates, some had bachelors. And then really we also looked at their confidence, because we had read several articles about confidence not really correlating to competence, so we were curious. And then we also asked them some other demographic questions about their level of experience. And our results were that they had a very high confidence level in the pre-questionnaire. They felt very comfortable with this procedure. As I mentioned, they were doing these skills almost every shift. But unfortunately, no one was able to meet the minimum passing standard in the pretest. So that attempt one right there, nobody was able to achieve it. And really the main things that we found were breaks in sterile protocol and masking the patient, which is part of our standard here. And really we expected a much higher result than zero, because these nurses, again, they were doing this every single shift. So after intervening and doing some deliberate practice, and again, you've identified their gaps in that pretest, we were able to get 55% of the nurses to mastery in attempt 2, and then of the remaining nurses, 89% in attempt 3. We did have one nurse that required additional deliberate practice after the close of the study and was able to achieve it in attempt 4.
And that's important to note because, again, every learner, every time. So eventually, so it was a matter of some of them needing a little bit more time and some needing less, but they all eventually got to mastery on this critical procedure that they were already doing on patients.
Right. Exactly. And really, this was the test for could this function with practicing nurses, especially the cultural piece. Like, does it mesh well with our current educational practice? And so that was a good test for it. And then really, this also uncovered some possible next steps. So one of the things that we heard back in our program evaluations from learners was these themes about culture of safety. So a lot of people said things that they were going to change in their practice following this SIM-based mastery curriculum was inviting a peer in at the beginning of the procedure, saying, hey, I know you're holding the patient and helping stabilize them, but could you also, let me know if you see anything that's concerning, like you see a break in sterile protocol, or you notice that, I missed a step. So they were welcoming people in at the beginning. And people also mentioned that they would use a checklist, a procedural checklist that was available to them prior to doing this intervention, but nobody really utilized it. For those of you in healthcare, you understand. So we were curious because this was somewhat of an unintended secondary outcome. So we were interested in looking in more formally at this culture of safety concept.
And I would say unintended, but those things were actually embedded in that checklist because we looked at what our current standards are and at that checklist that people were not necessarily using as we created the tool and the actual simulation. So as part of the simulation, we asked them that they invite, as they were trying to do their mastery and their deliberate practice, we asked them to note there is a second person that's going to be holding for you, use them in this way. And so we really embedded it into our sim, and it turned out anecdotally it did transfer into the real environment and impacted something very big that we weren't necessarily looking at, the culture of safety, but it had this secondary impact that we thought was fascinating, that we wanted to try to see, can we look at that more tangibly as we move forward.
And then the other piece that we, after this seemed to work well in the culture of that unit with nurses, we thought, okay, where else could we bring this for preventable harm reduction? And our first step really was to expand it to all the CVICU nurses. So we brought this education to about 100 nurses in the CVICU, so really all the staff that works there. We went to we're a union organization, so we partnered with our nursing union to make it a mandatory education that everybody would have to achieve mastery. So that was a very important step to make sure that we had that formal logistics plan of, what does happen if somebody can't achieve it in 4 attempts, how will the education staff support them? And in addition to that, we also developed some buy-in from clinical nurses by bringing this to their education days, kind of prepping them to tell them that it's coming and will be coming onto their shifts. Because the piece that how we integrated this education was bringing nurses away from the bedside for about 15 minutes to do their pretest or to do a little deliberate practice in short bursts during their scheduled shift. So that really allowed us to basically be available to them as it worked with their flow of their day and on their shift.
And I think it's important. So as a physician, my lens is very different. And so the creativity that Brittany used to make this feasible and operationalize it were things that I would not necessarily have thought of. And I feel like that's really important to highlight here, that, because it's professionals that are already working in the hospital, not necessarily trainees, right? When we think about education and simulation, and most often we're doing it for either nursing trainees or physician trainees, medical students, PA students, but this was for nurses. And so to consider the implications of that, and to go to the nursing union. And I mean, that was a process and really had to be very well thought out and concrete to have it be approved, right? To make something mandatory for them and to have these consequences if they didn't meet mastery was a big deal. And so to show that we had done the pilot and this was really critical to their work and it was critical to the safety of the patients, because the biggest step they were missing was sterile protocol, was really important to get that buy-in, and then being creative in how we implemented it, right? This is a huge unit of nurses, and it's actually an understaffed unit with nurses. And so how would we not only get buy-in and not have them showing up really grumbly because they're just mad that they have to do something extra was really important. And as we'll talk about later, it was also important because of the nature of this educational strategy, where we start off when learners come in by saying you're going to take a pre-test, right? That language is not always very positively seen. And so again, it was really important to figure out creative ways to operationalize it, get that buy-in, so that when we did come in and say, okay, this is what we're going to do, we were already hopefully starting on a good foot to move forward.
Right. And a huge part of that was figuring out a lot of the logistics. So first of all, finding a space. So to make it as easy as possible for nurses to be able to step away for, like I said, 10, 15 minutes at a time. We were able to utilize a conference space that we modified to, brought in all of the equipment that they would have at the bedside, all of the physical pieces, so that they could really figure out, okay, where am I going to put my trash can? Where am I going to put my bedside table? Because that was leading to, how people set up their equipment led to their sterile protocol breaks. So really, we tried to make it as realistic as possible, but also accessible to them. So this is a mock-up of what the space looks like when we were meeting with learners. We also had to partner with a wide variety of people that could help us actually as raters and as educators. So we took the assessment tool that we had created. We were using the same assessment tool we used in the pilot, and we did rater training for infection prevention, helped us as raters, quality and safety. We have a unique role here as a quality and safety coach. Basically, they go to the unit and are an extra set of hands and a coach for quality and safety topics. So they're a lovely resource. So they were very involved, as well as our unit-based clinical educators were very involved. So they went through rater training. We also did some quality control before they met with people to make sure that the way they were giving feedback, the way they were doing the pre-briefing was consistent. And then, of course, how they were utilizing the tools, so we had inter-rater reliability. Because the last thing we wanted to do was have somebody come out and say, oh, they told me that this was wrong, but then their friend on the unit said, oh, I did that, and they didn't say anything. So we were very stringent on making sure we were going to have a consistent message. We really wanted to protect that buy-in by doing that.
And to make sure it didn't seem punitive. Again, with this strategy, we wanted to be very careful. So when we trained our quality and safety coaches, or those that we partnered with, we made sure, because you're getting a lot of very directive feedback here, which is a little bit different than in other simulation education strategies. And so to be very deliberate about training them in how do you give directive feedback in the proper way, and what kind of language can you use to do that? And because a lot of these, again, is very different than other sim where it's one-on-one and directive. So
right, exactly. So happily, all the nurses in the cardiac ICU were able to achieve mastery after this structure of using simulation-based mastery. And really, just like we said, there were varying amount of time. So some came in and were able to do it in the pre-test. And we said, bye, see you later. We'll follow up some other time. So they were, happy that that was possible, because, there is still some apprehension. We did have some learners who required as many as 3, or one that required 4. So there was a lot of variability, and it really wasn't consistent with, those who were really new, or those who worked the night shift, or any of those were not predictors for us on who was going to require more resources, which as an educator was somewhat shocking, because we make a lot of assumptions that, oh, it's going to be our new grad nurses that need this, or those that don't get a lot of exposure to the procedure because they're on nights or something.
Yeah, and this matches the national data that we've looked at, right? That even people who've been practicing a long time, or people even that are sometimes considered experts, are not necessarily experts, right, or not masters at that skill, or not doing it according to, the important thing here to point out was they may not be doing it according to the appropriate policies and guidelines that the hospital has laid out. And that's what we use to create what we call mastery. So that's also important to remember.
Right, exactly. So our next step really in expanding this is looking at skill retention. And I think the really important part of this is looking at return on investment. When we think about other educational interventions, like even just sharing a policy with the staff and saying, can you attest to the fact that you read this, those kinds of interventions don't really last very long or maybe make much of an impact. So looking at, okay, we're spending a lot of resource intensive to do simulation-based mastery, but how is that going to impact going forward? So other studies, as Dr. Boer was alluding to, have looked at skill retention, and they've seen even a year later that people can retain mastery in this skill. So we were very interested in that, especially from the perspective of nurses who are practicing. So we've designed a study that's actually still ongoing, that we're looking at participants who went through this initial unit-wide education, and we are doing a year and then 2 years, which, shoot for the moon. We'll see what we find. But we're curious, do they retain mastery, and then how long does it take to get them back to mastery if they don't actually achieve it in that baseline assessment?
And we've collected data at the same time about some of the same factors we looked at with that first study in terms of their years of experience, how often when they did this intervention and when we're retesting them a year later or 2 years later, how often did they actually do that skill, so that we can really think about skill retention in terms of, is it skill decay or is it skill drift, right? So they could be doing it a bunch of times all the time and they're drifting from the protocol, versus maybe they're not doing it all the time and they've forgotten some of the pieces or that sort of thing. So it was really important to us to really kind of continue to look at those things and how they correlate based on our intervention. And the rest of our slide is empty because the study's still ongoing, and so we didn't necessarily we weren't able to really share some of that data just yet. So we've done our 1-year follow-up already with all of our nurses, and then we're waiting we may look at that data. We haven't quite analyzed it yet because we don't want to influence ourselves as we move forward into the second year.
Yeah. And the other piece that we also tried to integrate here was a situational judgment test, and really that was a way that we thought we could look at the culture of safety piece that we've seen in our initial study, and really just kind of challenge staff using a scenario to see how they would react according to this scenario, to try to pull out, are they speaking up? Is that something that's important to them? Are they following all of the pieces for culture of safety? So where do we go from here? Was sort of like, okay, we've really focused a lot on the cardiac ICU, which I sort of felt, biased because it's where I came from. But we knew that there were a lot of other areas that could benefit, maybe not just from CLABSI reduction, but from other uses of simulation-based mastery. And I think the most important part was putting together some standard work to really help us pick through, how are we going to prioritize for future interventions? So we put together standard work for planning, implementation, and evaluation of SBML interventions, so that when someone came to us with a request, we'd be able to say, okay, this is your request, and it's supported by strategic plans by the organization, or we have safety learning report data that indicates this is a need, or we have a needs assessment that indicates this is a need. And that really, all of that information helps us piece through which one is more critical to respond to, because even though we're really lucky that I get to do this work as my job, that I'm only one woman. So,
and it's resource intense, right? So yeah. It does cost money, and even with Brittany's pilot project and then expanding it, we did a very careful budget analysis in terms of how much per learner does it cost, and really had to present it to our leadership in that format of ROI, of this is how much it costs per learner to do this intervention, and here's how much we're saving by preventing one CLABSI. And so really tying it to that ROI was important. That was part of our standard work of how we prioritize what we do.
So with that, we decided actually initially to go to the hematology oncology floor, which also had a higher risk population, obviously, for central line infections. They also had a need for this education according to their needs assessment, and they had CLABSIs that were reported related to these types of lines. So we went there, found very similar things. Sterile protocol, again, was the most commonly missed item, 60% of their staff actually in the pretest. And so really just, again, supporting people to get to mastery, whatever that might look like for them, and trying to maintain that buy-in so that it wasn't punitive. And Dr. Vora is going to share a couple other projects that we've done, again, using the standard work to help guide us. And she'll help kind of talk about the scope that we've used.
Yeah, so as we presented this, as we created our standard work, and then we were actually asked, because of Brittany's brilliant work in the CVICU and kind of, the leadership had already seen, like, wow, this is, a pretty big deal and could change the way we do things overall at the hospital in a lot of different areas. We were asked to present to our our quality performance committee, or board, it was the board quality at the time, about sim-based mastery learning. And so we did a similar kind of the first half of this presentation to them. And after that, so a lot of the leadership was in that room. And so we were really glad we created this standard work, because we then got a lot of different requests. And so we used our standard work to kind of help prioritize them and think about, where do we go next? And what we realized was, where we go next didn't necessarily have to fit into this box of a procedural skill, or the idea that sim-based mastery is for when we're working with one person to master a skill. And so the department head, the head of our radiology department, actually the leader of our radiology department, came to us and requested sim-based mastery, that we were getting Children's was getting a new MRI machine, and it wasn't necessarily that we had bad outcomes, or some of our previous thoughts about sim-based mastery and our interventions were related to a needs assessment of seeing, oh, we've got CLABSIs and we've got these issues we need to address. And in this case, we didn't necessarily have any big sentinel events or issues, but a new MRI machine was coming, and we understood that this was this timeout process for MRI technologists was kind of a team-based task. And so we really thought about initially, is it really appropriate for sim-based mastery? But kind of looking at our standard work and really thinking about this as we're working within a hospital-based organization, and although this is a team-based task, we knew that they came to us and said they were having some compliance issues, and we wanted to give a chance to our MRI technologists. So there's a couple of reasons we accepted this request. Was we wanted to give our MRI technologists to kind of show that, as we heard from our leaders, they were very invested in their role and doing these timeouts properly, but it was a team-based task, and we wanted to see if we could use sim-based mastery to uncover some of the gaps that might be present within the overall process. And so then, so although sim-based mastery itself is a conceptual framework, and that is the foundation of what we used, we also, because we were using it in the context of thinking about the process and the gaps we could identify, we also use this conceptual framework, Lewin's change theory. And I don't know how many of you are familiar with this already, but it was something where we thought this will fit well, where you use this to kind of look at a process and unfreeze it, so you can look at all the different pieces to figure out, well, where are the gaps and what can we do about them? And that's where we used our simulation-based mastery intervention, right? So we went in, we developed a simulation similar to what we talked about with a standardized participant to be, the physician, and so it was a team-based sim in terms of, but it was really geared toward the MRI technologist gaining mastery in doing a timeout. And so we had a standardized participant, we developed a scenario, and they got a chance to run through this scenario. And we embedded a challenge in it where, they get a little pushback from the SP, and there's some hierarchy there as well that they have to address, and they have to, in their role, step up and say, no, we have to do this timeout in this way. And so we did that, and that was kind of our freeze process, embedding that challenge, having them do sim-based mastery. And we actually had every MRI technologist on all 3 of our campuses. So Children's Minnesota has a Minneapolis campus, a St. Paul campus, and then we have a campus in Minnetonka that does outpatient procedures and has an MRI machine there. And so we did all 3 campuses with our SPs playing a parent, a sedation nurse, and an anesthesiologist, and had the MRI technologist run through it. We had to partner, again, just like the other interventions, we had to partner very heavily with our radiology leaders and work with their schedules and go to their sites, those campuses, and really partner well with them to be able to fit it into their schedule to do these simulations. And then we also, because this was more about the process and not just about meeting mastery, after they met mastery at the end, we gave them the opportunity to answer some standard questions that we asked about the simulation and their perceptions around MRI timeouts in general. And all the MRI techs met mastery in the first attempt, which was a little different than some of the other sim-based mastery learning interventions we've done, but I don't know that it was unexpected to us. And they met mastery even with the embedded challenges of speaking up and that sort of thing. But we were told by our leaders that our MRI techs are good, they're assertive, and we really wanted to look at this overall process. And so we didn't think that that necessarily took away from the huge value of doing sim-based mastery, because those standard questions that we asked, we then were able to qualitatively analyze them and think about, well, what other things were important. And one of the things, let me move this up, it also gave us a chance to look at this as a team. So when we went into their environment and we were doing these simulations, and Brittany was the one that actually was hands-on on the ground, and she had these experiences that when she offered those questions after the simulation, that's when we got some of the most rich information. And I'll have her kind of share a little bit about that before I go into sharing our data from that.
Yeah, so one experience in particular was quite striking, I think we got this outpouring because of the intervention kind of gearing people up to discuss it. And one person in particular had shared that they'd experienced a code blue in one of their MRI suites a couple weeks prior. And really, when they were talking about the challenges and the barriers to doing an effective MRI timeout, this topic came up that, people aren't prepared to respond to a code blue in an MRI machine. And really that still, because the child is in the MRI suite, the MRI tech is responsible for still guiding that process, getting that child out of the suite so that they can get the care they need, despite the fact that they need resuscitation care. And that really was striking. She brought me actually up to the additional MRI suite that was on this campus to show the environmental impact that there was, because there were 2 access points into this room, which was different than the other MRI machines that we had. And that alone was striking, that she had to somehow, if she was alone in that room as a tech, she had to somehow be able to control both doorways when people are flooding in to try to care for this child who's coding. So it was just a really great experience, and we got outpourings of information when we asked these 2 simple questions.
And I think that highlights 2 things. One, we went in to do the sim-based mastery learning initiative with the technologists, and that prompted, so the educational strategy really gave them that chance to think about how they speak up and what this means for them. And they don't get a lot of educational strategies like this that come to them. And so I think they were very excited about that, and they were very excited to share. And it really created this buy-in into SIM and buy-in into, we want help, but how can we make this better? Of course, we want to do our jobs really well. And so I think that was really amazing. And so from that, they were able to talk about some of the risks they face. They were able to show us their environments. When we go with simulation, instead of having them come to our sim lab, to go to their space and see this and offer this type of an intervention was really important. And then from that, a couple of things. So I'll start with the data, and then we'll talk about some of the changes that they're working on now. So we qualitatively analyzed the data from the 2 questions we asked afterwards, and put it into themes. And the 2 big areas we asked, the 2 questions we asked were about what are the challenges they face, and then the other was about the positives of how the timeouts go in their environment and that sort of thing. And so with the challenges, these were the 4 kind of big themes, and the one at the bottom is the one that Brittany mentioned, the code blue risks, right? And so one of the sample quotes is, "PICU doctors in the control room with the crash cart, RT standing in the room, and no one's listening when stating that we need to get the kid out." And that makes sense to me, right? My physician lens, I'm focused on the kid, and let's resuscitate, forgetting where I am, and just bring the code card in and try to get it in. And there's 2 doors for this tech to try to keep me from taking it in. And so this was really important to think about and address, and we'll talk about this when I talk about what kind of changes that could be recommended to them after our intervention. And then the other ones, some of it was all around non-compliance, and why were the things that we looked at as we qualitatively analyzed. And one was lack of knowledge. There are pieces of things that people come someone with and they don't even realize, right? They're always wearing bobby pins and they think they don't need to take those out, or they sometimes are like, no, those aren't an issue. Lack of engagement, and this was more around, right, so if an anesthesiologist or a nurse is there and they are going in for multiple MRIs during the day, they have to do an MRI timeout every single time. And so you can imagine sometimes people are checking out or not as engaged in that timeout, which can be problematic. And then environmental risks, and we kind of talked about that as well. There's specific MRI safety forms that, maybe need some clarification or updating, which was pointed out to us by the techs, and some other things that were looked at. So these are just samples of some of the quotes, and there's some other things that kind of fit into these themes. And then the second big thing was the positives they shared, right? Compliance, and we noted, like I said, that sim-based mastery learning gave the MRI techs the chance to show that they are assertive and they are very serious about their job and understand what a huge, how important it is and how it into the safety of the patient. And then the other themes here that, it's repetitive, which is positive because it gets people used to it. And then they do have a pretty good process in place in certain areas. And so this led us to recommending a few things for them in terms of the code blue safety, potentially adding something on their forms at the very top or somewhere where every person that's about to come in is going to see it every time, right? Remember, the kid needs, code blue, if there's a code blue, kid needs to come out, and that sort of thing. And so we recommended a couple of things to them of how to follow up this intervention. So a lot of good came from it, even though we didn't necessarily, wasn't necessarily focused on the MRI text, not, having to get to mastery. And then for the sake of time, I'm going to keep moving forward. And our next thing, so that was pretty, I think, unique for us to go to an allied health professional and use this kind of intervention. So then we got another request within this kind of same time frame over the last 2 years from our neonatal nurse practitioners. And one of the things they came to us, a couple of things they came to us to say was that they realized as they were hiring on new NNPs, they were realizing that the NNPs had varied experience based on where they trained and how much experience they got there, and what kind of procedures they had a chance to do or leading codes. And, they might have had limited exposure to resuscitation and leadership skills. And they noted that the transition from being a nurse to a provider was challenging, right? Specifically in the area of being able to lead a team and having those leadership and communication skills that are very much needed, or maybe not even necessarily having them, but using them was challenging in that clinical environment for some of them. And so they asked us, what can we do? And so we thought about sim-based mastery, and this time we really thought these are new NNPs coming in, and so we wanted to use a boot camp style or some form of that where there's, heavy intervention when they first start to really get them up to speed before they get onto the floors. So our goals with this were for the new hire NNPs to reach, mastery with leadership and communication skills and procedural skills. And so these are kind of the objectives we had set out, and we tried to, again, as we look at all the mastery interventions that we've done, we always try to go back to things that are evidence-based and already in the literature. And so even for this, although sim-based mastery hasn't been done for leadership and communication skills as far as we could see in this arena, we did go back to some of the tools that are already laid out. So we used team steps, we used NRP behavioral skills, something that NNP should already be familiar with, and we used their national orientation kit, again, that we think that most places around the country, and at least ours, were already using. And so it wasn't necessarily introducing new knowledge or new things that were never heard of, but really using what they had and putting it into this construct. And then also we picked the procedures based on the information we got from our NNP leads in terms of what was most important when they first got on the floors, right? This was something that regardless of what their experience had been before they came in, it was really important for them to be able to do these procedures as soon as they hit the floor. So intubation, umbilical lines, and chest tube insertion. And so that's how we came up with our overall goals of what we were going to do and our objectives of where they were going to meet mastery. We used those, and back to the leadership and communication skills, we used those national guidelines to create our scenarios and then to create a checklist. And that took some work because we worked with our NNP leads. We have 2 different campuses, And so to really take into consideration what their current practices are as we put these tools together, what are the expectations for the NNPs? And they might vary at various institutions. And so we had to really look at least our two campuses and see, right, are they supposed to be, responding to a delivery, and at what level leadership do they need? And then to try to standardize it, right, to the highest level is what we did. Basically, even if at one campus they may have the neonatologist with them anytime they respond, they still needed to have these skills, is what we heard from our NNP leads. And so we standardized our scenario, at least our mastery scenario, to that, where they had to be able to demonstrate these skills. And we had embedded challenges in there where they had to demonstrate, direct things from team steps like check back and closing the loop and giving handoffs, that sort of thing. And so those were, and then we scaffolded scenarios in between. So that was also a little bit different, where it's easier with the procedural skill, right? When you think about deliberate practice, yep, intubation, here's a checklist, and if you don't meet mastery, you practice the procedural skill and pick the pieces that maybe you weren't so great at. And so we had to take that construct and use it for leadership and communication skills. How do we use that same construct? And to be honest, it took a little bit of piloting and iterations to realize that's what we wanted to do. Because we first started with multiple clinical scenarios where we thought they were going to have to meet mastery in each of these scenarios. And what we realized was we took our most difficult scenario that incorporated all of those skills and decided that was our mastery scenario, and used the other ones for deliberate practice of the skills, because it was the same skills we were trying to teach them throughout those scenarios. And so that actually made it easier, because we think about how resource intense mastery is. To do it that way actually helped, and I think the learners appreciated it, right? Because there wasn't as much pre-test and post-test, and we're trying to push a lot of information and a lot of scenarios, which felt like it was harder for them. So that was really important. And then, so this is our flow of how we did that. So we developed our tools, we worked with our NNP leads to develop those tools, and we piloted it and then had some iterations where we added some sessions for deliberate practice, is what we really added into here after our first two runs. Where they get, a survey at the beginning, they come in and they do their pre-test, they get to do deliberate practice, and then they do their post-tests and master out of these procedures, and then we jump into leadership and communication skills until they meet mastery. And then in this particular study, after we kind of tweaked it and figured out our sessions and our tools and all that, we then also said, well, we also want to look at how does this translate to the bedside. So as they reach mastery in these things in simulation, is it translating to the bedside, these leadership skills and the procedural skills? So what we did was have them master in the simulation environment, and then have their preceptors, because they were still in orientation and being observed, we're having their preceptors, and this is an ongoing study right now, have their preceptors fill out the same forms that were used in simulation to see if they were meeting mastery at the bedside. And then one of the things that we found while we were doing these simulations with our new hire NNPs, although we haven't formally looked at the data or analyzed it yet, there was a couple of things that we realized. One was, even with our NNPs so some of our NNPs, like we said, they come in with varied experience, right? So some of them may already have been practicing and some of them actually had been on orientation for a while before they did our boot camp. They still came in and really appreciated the deliberate practice. It allowed them to focus on different aspects of the scenario instead of they would say things like, well, I was focused on the intubation part of the scenario, but doing it in simulation in this way and having the opportunity to deliberate practice, I could focus in on the team skills and really hone those in. And they got to pick what they did deliberate practice on based on their pretest. So they really appreciated that. All of our learners were able to reach mastery, and the max attempts that they needed were 3. And that's important to think about as we think about feasibility and how are you going to make something that this was a pretty big scale in terms of doing actual clinical scenarios, simulation scenarios to mastery. And so now we took this and we're trying to work to collaborate nationally. So if there's anybody out there who wants to collaborate with us, we're looking at other sites who might be willing to adapt our curriculum and see if their NNPs, not a lot of NNPs are hired at most organizations, is what we found even as we reached out and talked to other organizations per year. And so to really get that up and running and see how this works at other organizations and see how much, and so far we found we may not have to tweak very much of our curriculum. Most of the places we've talked to actually struggle with the same issues that we do. They come in with varied experience and knowledge. And so we're also working on a train the trainer module to make it feasible to be able to share this curriculum nationally and disseminate it realistically. So I'll pass it back to Brittany to kind of wrap things up here, and then we'll take some questions.
So the pearls that we wanted to share for operationalizing an SBML curriculum or SBML program at your organization is really that we recognize it's resource intensive, and to call that out ahead of time, because really it will take more resources than a lot of other formats. And I know that other organizations probably won't have a dedicated role for this work. However, I think it does partner very well with other simulation work that a simulation specialist might be doing, or even an educator role, a nursing educator or a medical educator who's trying to grow the curriculum that students or practicing health professionals would go through. And I think the biggest piece for us was finding partners to develop those tools, so having content experts, and then really also helping with those logistics. What is the physical space? How are you going to get these learners to you? Are you going to go to them, or are you going to use your sim center? And then really process improvement. The two projects that Dr. Vora described, we've had many iterations of in order to make them as approachable to the learner and as productive as possible. So those, with that, I think we'll throw back to Justin for any questions.
Yeah, and then our references, we've got our main ones that we actually quoted in our slides, but if you want the actual longer list, it's quite a bit longer, you can email us for those.
We'd be happy to.
Yeah, we'd be happy to send those.
Well, great. Well, thank you both so much for your talk. As a reminder to the people listening, in the questions tab, you can type in a question, and I will read it out loud and get the response from our presenters today. So I wrote down a few things that I'm just kind of curious about. And the first one, and so I have a little bit of experience with mastery learning. My fellows project was actually a mastery learning project, and one of the hardest things for me in my project was determining the minimum passing score. And so I'm curious to hear a little bit about your guys' approach to that, and now you're looking at doing it for multiple different procedures. Have you kind of nailed that down a little bit, I guess?
Great question.
Yeah, we've actually used the patient safety method by Yudkowsky, and that seems to work really well for our content experts. It's an easy method to describe to different content experts. And then also Mastery Angoff was also really helpful for us. And again, we were lucky enough to be able to go to the Northwestern course for simulation-based mastery, and it was helpful to get some hands-on practice on using those tools and even seeing how they facilitate rater training and the content experts to set those standards.
And we had to be creative in terms of our content experts getting their time in terms of doing a modified Delphi, trying to do it online, trying to do call-ins, or we could, do things through that fashion. And so using those methods and then some creativity of how you got your people together to set that minimum passing score was how we kind of did that. Does that answer your question?
Yeah, no, it's painful anyway.
We haven't found a way to make it less painful, but yeah.
All right, looks like there's a question posted. So from Pooja, and forgive me with your last name, but Nawati, would you envision SBML being applied to PICU CV ICU attendings for leadership/teamwork skills?
Yes, please. That sounds amazing. Yeah.
And if you'd like to partner with us in doing that, we could probably do that here with our PICU attendings too. I think that's something that really, as we've gone through this process and done it with different learners, I really think about this is a challenging, and so I'll kind of share a challenging construct for people who are already practicing. And so then you think about physicians who are already practicing to tell them they're going to come in and do a pre-test. And that's why I kind of said earlier, you have to be very deliberate about how you phrase things and how you frame things, right? Your pre-brief and how you explain what the purpose is and how it's going to be done, I think is really important, especially with that group of learners. But I think that would be a fantastic place to to really use some of this knowledge, or with like attendings for traumas, is another place I would think about it at our organization. But yeah, PICU attendings for leadership skills and running a code, or in general. So we also, with our NNPs, that translational piece we're using with that leadership and communication, it's not necessarily just in resuscitations, but that form can be used, that checklist. And so some of the things during rounds, how they display their leadership skills, are things that we're hoping to capture as well. So I think that would be a great place to think about this.
Pooja just typed in another question about being able to unmute and talk, and I don't think attendees can. This is as a function of the webinar, but not to speak for Brittany and Samarine, but I'm sure that they would be willing to communicate with you offline if you had further questions or wanted to communicate more. And it looks like on the slide there are their email addresses. So.
Yeah, definitely. Please do email us. We would love to talk more.
Another question, go ahead. I actually really enjoyed and appreciated the return on investment approach. And I'm curious to hear just a little bit more about that and how much you've kind of contextualized that, or like objectively identified that, or have you done much? Tell me just a little bit more about what you've done with that.
So we still have that open retention study where we also are tracking CLABSI rates ongoing as well in that one particular unit. And that really is part of how we're measuring return on investment. Is, CLABSIs in the pediatric setting can cost as much as $90,000 by some reports for a neonate. So if we can, even improve our CLABSI rate slightly, that return on investment argument becomes much easier. But really, we tracked the personnel time. So looking at how much time are we having facilitators be with learners for deliberate practice, because sometimes they're doing it independently. That's what they prefer for their own deliberate practice. And then also how much time are we spending in those assessment sessions. So that, in addition to any supplies, is what we've tracked, and then looking at, based on how many learners we got through and how much that costs. So the actual return on investment argument will be easier to look at once we're done with this study. But really, from a budget standpoint, from the education department standpoint at least, it was a easy argument to make, because many people were doing hands-on, different, like, coached education sessions in their ed days that they do for nurses. And so we were saying, okay, can I take those supplies and just move them to a sim mastery format, which obviously the personnel time is the most costly piece, but at least we were saying, okay, you're already doing X. Let's just beef it up a little bit and see if we can get a better skill retention. Does that help answer that question?
Yeah, no, it's great. I just think, yes, and I think one of the things that's interesting to me is thinking about how to show the benefit of simulation in general as far as patient outcomes. And I think that's kind of the next phase for simulation-based learning. And cost is always a nice kind of easy measure to track. And this seems like it lines up pretty perfectly with that approach. So, well, those are the questions that I had, and it doesn't look like there are any listed. So I'll take a moment to just thank you guys again, and to thank our participants for joining us today. And just as an FYI, the webinar participants will receive an email from us at IPSS that includes a link to an evaluation. Please take a few minutes to provide your feedback on today's session. And additionally, the recording of today's webinar, along with the handouts, will be posted on the IPSS website in the near future. And I will close just by reminding everybody that there will be more webinars upcoming. We are working on scheduling one for June, so be on the lookout for that. And if you have not registered for IPSSW 2019 in Toronto, please consider doing so. And we look forward to seeing you all in Toronto, May 20th through the 22nd. Thank you.
Thank you.
Thank you.